And get going right away. And thank you so much for being here for this co-sponsored seminar from the HIV Center and the LGBTQ plus initiative program at NISP, New York State Psychiatric Institute, and Columbia University. Glad you're all here, and we have a very special guest today that I'll be introducing in a moment. And let me mention that in upcoming rounds, another one this December, that will be in person. There is a virtual option, but we want to encourage as many people as possible to please join us in person in the multipurpose room, our usual location, on Thursday, December 18th. And we have Suzanne Goldberg, who's a professor in the law school and has done a lot of work in government and is, just a really senior person in the field and a real expert. It's going to be a really stimulating, fascinating discussion. The title is Rights, Risks, and Justice: Understanding the LGBTQ HIV Legal Climate. She's going to share with us some very, very important and timely information. And it would be great to have as many people as possible in person in the room on December 18th. So make note of that. Okay. Unless Chris or someone would want to make any other announcements, I'm going to introduce today's speaker and also remind people that this presentation today is eligible for continuing education credits for psychologists and social workers. And Chris will talk more about that and how you can collect those credits. So please keep that in mind. We're very pleased today to have Dr. Bryan Kutner with us. I think many of us, of course, know Bryan, who was a postdoctoral research fellowship with us here at Columbia and with our HIV Center, and then became a research scientist and assistant professor of clinical medical psychology in our psychiatry department here at Columbia before he abandoned us. No, he didn't go very far, and he's still a colleague. And he's now an assistant professor in psychiatry and behavioral sciences at Albert Einstein College of Medicine, and also in their medicine division of general and internal medicine in Montefiore Medical Center. So he's nearby, and he is, like I said, still a colleague with many of us. Bryan got his undergraduate work at Yale College. He got a master's in public health at Columbia, along with then a master's of science and PhD at University of Washington. I'll keep the rest relatively brief. Bryan is a clinical psychologist and behavioral health scientist. His research aims to improve HIV service quality and health by enabling healthcare workers and systems to address stigma and other barriers to equitable health services. And I think you'll see that in his presentation. He specializes, and a lot of us have witnessed his really expertise in training in motivational interviewing, which is often incorporated into research. And I think, makes a big difference in the kind of research he does and the outcomes of the research and the support of translating research into actual practice. So without further ado, I'm going to turn it over to Bryan, and thanks so much for being here.
Thanks so much for the introduction, Bob. It is really nice to be back at the HIV Center, even if it's virtually right now. I'm going to walk you through this project, which got some of its origin story comes from the HIV Center when I was a postdoctoral fellow. Some of it goes a little bit further back too. And this project is called Peaches for short, but in the public-facing view, it's called the Anal Pleasure and Health Project because it's meant to be something that clients and providers can use. And so we'll walk you through what we developed and how we evaluated it. There's a take-home message here, which is that environmental changes are what drive stigma reduction. And so I'm going to walk you through the whole project and arrive back at this take-home message at the end. And it's our working hypothesis for future work as well. I want to tell you a little bit more about the origin story from years ago. So this is an ad that's advertising a bathhouse, a public sex venue. And in about 2006, I moved to New York and I started to moonlight doing HIV counseling and testing in bathhouses in New York City with a project that Dr. Dimitri Daskalakis, who was at the CDC and now is going to be coming back to New York at Callan Lord. He developed this project, and many times I would find myself seated across from a client who would say something like, "When I have anal sex, I bleed. That's normal, right?" And it happened repeatedly, something like that, enough that it got me thinking, how is it that someone who's been having anal sex for years, if not decades, knows to test for HIV and STIs, but somehow has not gotten this message that if he's bleeding, he should really get that checked out? Around the same time, a friend of mine, a woman, this is Bette Midler, is a stand-in for my friend. Bette Midler got her start in bathhouses, singing in bathhouses, to be specific. My friend is walking down 8th Avenue in New York, had just come from the gynecologist, and was talking to me because she was really distraught. She'd been in the stirrups being examined, almost finished with the exam. And she said, "Oh, could you look a little bit lower? There's a little bump that I felt." And the gynecologist looked lower and said, "Well, that's an anal wart. Have you been having anal sex? Are you married?" And then proceeded to burn off the wart in a very painful way. And so my friend is walking down the street calling me physically uncomfortable and emotionally uncomfortable. So it got me to think, okay, there's clearly an issue with clients needing some information, but also it looks like providers don't know how to work in this area. Eventually, as Bob mentioned, I went back to school for a degree in epidemiology at Columbia, and then I went on to a PhD at University of Washington. And I really wanted to try to understand this phenomenon, in part because I had developed a workshop. I had worked at the Harm Reduction Coalition in the late 90s, and so I knew about training and education. So when I was at the bathhouse, I just developed this workshop, and then I decided to go back, workshop for healthcare workers, to learn how to do this kind of work. And then I went back to school. And when I went back to school, I thought, maybe I can study it. But the main question I was faced with was, does this have any kind of public health significance? So I'm going to walk you through 3 projects that started in around 2015, and then some of the future directions. And I'm going to focus mostly on this K23 project today and the results of that project, but I want to give you some context to understand where it came from. Let's start with this first project. So the main question here was, does stigma toward anal sex impede client uptake of HIV interventions? Really, that question is there some public health significance to this? And so we did that by developing an anal health stigma model, and we interviewed healthcare workers and consumers of services from around the country. And then we developed a scale. We then tested that scale and then evaluated associations with HIV service outcomes in a structural equation model that was quite large, cross-sectional. And here's what we found. The respondents who reported high internalized stigma, anticipated stigma, and experienced stigma reported less comfort talking about anal sex in a healthcare setting. And you can see this borne out in one of the quotations from a provider we interviewed in the formative work. I think patients know the majority of providers don't want to deal with their bottoms. So many providers will send their patients to me just for a rectal exam or to do a swab. It takes just 30 seconds. They don't want to do it. They don't want to go near it. And so it creates a kind of baseline stigma there. Oh God, nobody wants to deal with you associate it with poop and smelling and farts, all the above. Then you get a sense that your primary care provider or somebody else doesn't want to deal with it. It makes you feel like there's something wrong with that. So you can see how experienced stigma can become internalized and then anticipated and lead to less comfort. And that in turn was associated with less engagement in both biomedical and behavioral HIV prevention, less likelihood of receiving counseling, less likelihood of testing, less likelihood of PrEP, less likelihood of adherence to PrEP or to ART, less likelihood of ever having had an anal swab or STI screening as well. This is the whole model, which is very complicated to look at, but the reason I'm showing it to you, even though it's basically the simplified model up here in the corner, is something interesting related to social support. We controlled for other stigmas and sociodemographics, but this social support is particularly important. It is an indication that if I know someone who can give me information about anal sex and provide emotional support around the topic, that is associated with less stigma, more comfort talking about anal sex with a healthcare provider, and more engagement in HIV prevention in all those different areas that I mentioned. So from this project, we're trying to answer this question, what do we learn? Well, we've got one mixed method study, and it's telling us we can quantify anal sex stigma and that it has some public health relevance. It's telling us specifically that comfort wholly mediates the impact of stigma. So that's something we should try to operate on. And also that social support is a potential intervention target. Okay. Flash ahead a few years. I'm now at the HIV Center. I finished my doctoral work, and Dr. Katrine Myers here at the Aaron Diamond AIDS Research Center heard that I had this workshop that I had done from years before, but had never studied, and asked me to deliver it in China. And so we created a research project from that. And the question for that was, will HIV workers find strategies to mitigate anal sex stigma acceptable, feasible, and appropriate? I had this workshop that I developed through the Harm Reduction Coalition, kind of born from my direct service work, but it had never really been evaluated, and we really wanted to evaluate it. So I want to give you a sense of what the workshop is. It's called Smarter Sex is the New Safer Sex, Anal Pleasure and Health. And it's a 2-day in-person workshop for HIV workers to increase their comfort, knowledge, and skill with the menu of options available related to anal sex. And we did that in a couple ways. We focused on anal physiology and sexual response during anal sex. So we taught people physical structures, sources of pleasure, answers to frequently asked questions from clients. And then we also trained them in skills and how to communicate with clients that would naturally lead toward HIV prevention. So we trained them in motivational interviewing, gain frame messaging, and using a pleasure focus. And when we evaluated it, we were looking at acceptability, feasibility, appropriateness. I want to give you a sense of what people thought in terms of appropriateness. Here's one healthcare provider who said, I think regarding knowledge shared in the training, we always tell people how to protect themselves, but we don't know how to talk about pleasure or improving one's sex life. As far as I know, no one has done that. I understand that we're always able to tell people what they shouldn't do, and we're not able to tell them what to do. What we learned from this project is 3 main things. The first is we were able to normalize anal sexuality, and in particular, that increased providers' intentions to talk about anal sex with additional patient populations, not just gay and bisexual men. And then additionally, their increased knowledge seemed to increase their own comfort. But they said that they needed more to increase their clients' comfort. They wanted brochures and online materials and like conversation openers to kind of help things get started. And then I mentioned the role of social support before, and we should say that some of these healthcare providers were people who had anal sex themselves, and some of them found the content to be personally meaningful. So here's someone who said, the training has changed my mind that anal sex can be painless. I thought pain must be a normal phenomenon in anal sex. However, after the training, many of my previous ideas have changed. So all of that work then led me to want to try to understand whether there's something we could do in the United States and augment the workshop, because it seems as though the workshop might be helpful, but probably insufficient. And the main research question for this K23 project was, how can we enable HIV workers to address anal sex stigma in the United States? We had 3 aims in the project. So the first aim was to explore techniques and mechanisms that mitigate stigma during healthcare encounters. And we did that with a rapid analysis of interviews and surveys based on the capability, opportunity, motivation, behavior model, or the COMB model, which says that for behavior to occur, for a healthcare provider to be able to talk about this and address it, they have to have the capability, the opportunity, and the motivation. And I just want to draw your attention to the word mechanisms, because it's not sometimes a little bit of a funny word to talk about. A mechanism of action, at least in the way that we conceptualized it, is a proximal outcome on the path to behavior change. So if you have some implementation strategies which are meant to eventually improve service outcomes, for example, a workshop like we had, eventually you want that to change behavior among healthcare providers so that they can address anal pleasure and health within HIV services. And eventually that should, we hope, have some service outcomes. But the mechanisms of action are somewhere in between, the proximal outcomes. So you implement some strategies, hopefully that increases knowledge, comfort, skill, some other mechanisms, and then that increases the behavior change or triggers the behavior change. And I'm bringing this up because this project on anal pleasure and health could seem like very niche, like why are you studying that small thing? And what does it have to do with the larger field of trying to address stigma? And I want to say my bigger interest really is in what does and doesn't work to address stigma in healthcare settings, in particular related to HIV services. And these mechanisms and understanding them for this smaller niche project really can inform the larger effort too. And part of that is because we do have some understanding of what can reduce stigma, but across studies, it's hard to compare findings. And if we really want to be able to reduce stigma, we have to be able to organize the accumulation of that knowledge in ways that allow for synthesis across those study contexts. And one way to do that is with ontologies. These are formal, explicit definitions of theoretical constructs and their interrelations, but beyond a single theory, they're trans-theoretical. So what they allow us to do is to define mechanisms of action and also relate them back to implementation strategies or the kind of techniques that are used to trigger those mechanisms of action, and also then categorize behavior change as well. So we did that in our study in AIM-1 through the use of the Combe model, because the ontology that we used is based in that model. And then in AIM-2, we developed an intersectional package of strategies to enable HIV workers to mitigate anal sex stigma. And we did that with an 8-person advisory board, many of whom were participants in this first phase. And then eventually what we wanted to do is evaluate the strategies in 2 regions with the AIDS Education Training Center. We wanted to make it very real world and implement it in a real world context. We looked at implementation outcomes and impact on mechanisms, also on healthcare worker behavior and patient uptake of anal sex related HIV services. In this case, anal rectal STI screening was the primary outcome we were looking at. I'm going to focus mostly on everything after this plus. I won't go into the implementation outcomes unless people want to discuss that later. And the design was a sequential mixed method design. And then we piloted interrupted time series data collection for these patient level outcomes as well. We used ontologies to assess the techniques and mechanisms in AIM-1, ontologies to conceptualize the strategies in AIM-2, and then ontologies to actually code what we delivered in AIM-3. So I'll get into AIM-1 a little bit. This is to explore the drivers and the mitigators, the techniques and mechanisms that could shift that and be facilitators. We did interviews across the country, we used the Combe model, and we used something called the behavior change wheel, in which the Combe model is situated as a way of helping us to understand things and then eventually lead to development of a set of strategies for intervention. So barriers, this is not going to be rocket science for you all. You all probably going to be like, yeah, that makes sense, but it's nice to have it documented in a study. So one of the barriers in terms of motivation is people's emotional discomfort on the topic. And then for providers, their ambivalence about their professional role, their responsibility, and their personal values discussing anal pleasure. Like, is this something I really should be doing in my role? In terms of opportunity barriers, there is stereotyping of anal sex as gay, even though really the prevalent studies suggest really there are far more women having anal sex than there are gay and bisexual men. And that really it's just a matter of anyone on the planet could be having anal sex, but it gets stereotyped and therefore limited in terms of how people consider discussing it and intervening. And then a lack of educational resources, and also in services, anal health typically is just not routinely addressed as a topic. In terms of capability barriers, there was a lack of awareness about several things. About sexual diversity, like I mentioned, kind of the diversity of people who are engaging in anal play of some kind. Sources of pleasure and language that people use to describe pleasure and anatomy, anal health conditions and how to care for them, and also the consequences of stigma on health and services. People were not fully aware of that and said that would be something that could interfere. And lack of skill to normalize discussion and difficulty regulating emotions. These in particular are about providers feeling anxious and feeling discomfort themselves with the topic, but also saying, you know what, I don't know how to gauge whether my client is going to feel comfortable talking about this. And I don't want to do anything to make my client feel more uncomfortable. So I don't know how to bring it up even. And then in terms of facilitators, in terms of capability facilitators, knowledge about cultural norms why people engage in anal sex, and also what anal health medical interventions exist. So things about prevalence, anatomy, physiology, common problems, rationale and evidence for focusing on pleasure rather than risk. This is one that's particularly interesting. And so I'll share a story of someone who was a therapist who was interviewed in this formative work and worked mostly with gay and bisexual men who were living with HIV, and said, they want to talk about sex, but I don't think that's appropriate. I don't want to talk about it. I'm here to talk about anxiety and depression and those kinds of things. So I veer it over to mental health all the time. But then over the course of the hour-long interview, he started to kind of convince himself otherwise. Not that I was saying anything to convince him. He just sort of heard himself and he said, if that bridge to evidence that anal pleasure and health is relevant for my clients, if that could be illustrated, I think I would be among the first to begin having more purposeful, intentional conversations like this with my patients. So you can see how there's a potential facilitator just happening by letting people talk about this aloud with another person. The opportunity facilitators were about access to empirical support, like what this previous participant just said in that quotation, social contact with people who have anal sex, educational opportunities for skill development to reinforce professional responsibilities, like really let people reflect on their values. And then also restructuring the clinical environment. This was particularly key. People said they wanted scripts and algorithms and checklists to support assessment and education. And they also wanted standard of care testing. They thought, if you make sure that everyone is offered anorectal STI screening, then that's sort of an entree into being able to talk about the subject. And then they recommended visual cues that communicate a safe haven, like buttons or, things you can put on your lapel or lanyards. Here's what one person said. I think it just comes down to exposure kind of at the end of the day. And I feel like a lot of clinicians may not even have that sort of exposure to people who have anal sex and who talk about it. So they're suggesting there's a social opportunity maybe of making sure people can have that kind of conversation with colleagues. And then this is the physical one. In the same way that they have random diagrams of all the different pills that folks take, I think they could just as easily have diagrams or at least pamphlets with educational material. Because relying on people to ask for the information, knowing that it's highly stigmatized, it's not going to work. So all of that led us to two target behaviors that we wanted to initiate with providers. The first one was to increase provider expectations that anal pleasure and health can be an appropriate topic, and also enable them to communicate in a sex positive, accurate, destigmatizing fashion about anal pleasure and health with their clients. There are two ways we thought we would do that. The main ways were to operate on capability and opportunity. And the first with capability was to increase their knowledge and comfort. And then it was to restructure their social and their physical environment, to give them the opportunity to learn and also to talk about this with their clients. So we came up with two main strategies. There's a training strategy. These are implementation strategies. There's a training strategy and there's a quality improvement strategy or set of strategies. So the training involves the workshop, which I mentioned before. It's 2 days to enhance knowledge and comfort and skills. And then we added coaching calls to make sure that we had a chance to consult with people over time as they got back into their workplaces. So there's about 3.5 months of the coaching calls, 4 of those to reinforce skills. And then we also realized we needed to initiate and sustain changes in the clinic environment in order to enable that discussion. And so those QI strategies are the placement of visual cues, as well as quality improvement meetings in a subset of clinics where we would be able to deliver that given our budget. I want to just be very concrete with you. So here's an example of some of those visual cues that we developed. So you're looking at a certificate on the wall in 2 areas. And you notice here, there's like a little pride flag, right? So the function of that pride flag is very similar to the function of this certificate, as well as this poster. And this is an example of a poster that we developed and then sites could put in their environment. And you'll notice there's a little scan me here because everything that we developed is linked to a website of resources that can educate clients, but also be a resource for clinicians. And I'll walk you through the website toward the end of the presentation. But I just want to make sure we're anchored in some of what we actually developed. I also want to say for everything that we developed in terms of strategies, You see the training strategies up here and the quality improvement strategies. We coded them in terms of ontologies, in terms of the behavior change wheel and the comb-B model. And so all of that is cataloged so that we can then facilitate eventual synthesis of our study into and with other studies that are trying to address stigma. All right, let's get into AIM-3. So this is the pilot and evaluation of strategies. So this is where we delivered TEACHES in its entirety, those two implementation strategies of training quality improvement. And we partnered with the Southeast AIDS Education and Training Center. We did, as I mentioned before, an explanatory sequential mixed method study with 65 healthcare workers, and then we piloted an interrupted time series study collecting patient level data that was aggregated at the clinic level in 2 clinics that received quality improvement. And we did surveys and interviews before, during, and after PEACHES, and then we collected this patient level data about patient uptake of anorectal STI screening. We delivered the intervention in Tennessee, and then we did it again in Mississippi and Alabama. Originally, we wanted to deliver this in the Northeast in the second region, but we had difficulty finding a clinic in the Northeast that was willing to commit to the quality improvement. So we returned back to the South and did it there as well. You can see their average age. Most people identified as Black or African American. Almost all of them identified as cisgender, most of them as female. And you can see their education level too. I'm going to get into impact kind of broadly of the whole PEACHES package, or at least some components of it. Let's take a look at the workshop. Here's someone who said, I want to make sure also I'm very clear, these are all healthcare workers. These are healthcare workers, but some of them themselves have anal sex. So you'll see that some of what they're describing is impactful for themselves, as well as for their role as a healthcare provider. I needed the information for myself, especially if you're growing up a young gay person, especially within a Black community. Talking about sex, it's not spoken about. You honestly learn everything on your own. Well, when you don't know any better, you get information from people who also don't know any better. It's using the things that you would use for lubrication, like lotion, Vaseline, things like that. The workshop just became a full circle moment for me. I could educate my younger self when I see them in the community as clients, and when I'm doing testing events, and when I'm doing sexual education. Another reflection on the workshop, it taught me that if I teach people how to safely engage in anal sex and incorporate pleasure, they could naturally prevent themselves from getting certain STIs and prevent themselves from like tearing and hurting themselves. It's not always about like HIV prevention. That's not the main topic. The main topic is, hey, come and engage, use these tips and tricks to up your pleasure. And you're secretly also benefiting from harm reduction style methods as well. Now, what I've just described is, okay, we've got our PEACHES implementation strategies. It seems to be having some effect on behavior perhaps, but we haven't really like elucidated the mechanisms of action, exactly what is it that's changing before we get to behavior change. So I want to focus on that a little bit rather than more broadly just talk about impact. So what we did is in the qualitative work, data, including qualitative data from surveys and also interviews that we conducted, we looked at the relationships between different mechanisms of action. And this is a bit of a busy slide, but the take-home message here is in the hot pink. It is that these QI resources, you'll see, are a precursor to all of these other mechanisms of action. And so if you were to have removed QI resources or not included them, you would have been missing something that really is quite impactful on the mechanisms that eventually lead to intentions and behavior change. I'll walk you through a couple of these relationships. So here's someone describing how knowledge influenced empathy and attitudes. I really enjoyed that we learned the science behind it, because once you kind of know how everything works together, you understand why people enjoy anal pleasure and things like that, and just kind of takes out all the judgment because you now know the physiology behind everything. Some of these relationships between mechanisms were a bit complicated, but we really wanted to understand them as a way for us to then consider testing efficacy in effectiveness in another trial. It gave me the confidence and the comfortability to be able to talk about these things rather than completely ignoring them and putting up a wall to them, which is what I would have done before when I felt uneducated. Now I feel like I can plant some seeds And as I work with my patients more when they come back, I can ask questions and talk to them about these things without a lot of fear and anxiety. In terms of the QI resources, I'll just point out a couple of things. The button, I have it up in my office when I'm on a Zoom call or something. It's right in the background so people can see it. I've had some people in the office come around and ask me about it. So it does bring attention and make people open to talk about anal sex and anal pleasure. And here's someone saying, we always ask about anal sex, but we never really asked, how do you as the patient feel about anal pleasure? Or is that something that you want to discuss? Now that we have the right cards in the room, it's easier to bring up the conversation. And then here is someone who participated in the QI meetings who's saying, I think our patients have been really responsive to anal rectal testing and really grateful that it feels a little bit more comprehensive. They may have not even thought about testing in those sites, or maybe they have, but the fact that when we bring it up with them in a way, oh, we do this with everybody, we already have instructions up in the bathroom, how you collect it with an anal swab, just pass it through the window, we'll call you. I've noticed like a big uptick in anal rectal testing. So that's some of the qualitative in terms of the mechanisms of action, but we also assess these quantitatively, and you'll see what we assessed: people's knowledge and their skills, their sense of role responsibility, organizational context and resources, their emotions, their confidence, self-efficacy, and their ease providing social support, and their comfort advising about different topics that were relevant to our patient populations. And what you'll see is that after the workshop, all of these increased or moved in the right direction. So negative emotions decreased, all of them significantly. And then at the end of Peaches, so the end of the 3.5 months, is we're all fairly sustained. You'll notice that knowledge decreased, and this did decrease significantly between post-workshop and post-Peaches. But generally, these things were fairly sustained. And then in terms of behavior change, this is all self-reported. This is the frequency of sexual health assessment. And I want to point out something here to begin with. So in terms of people asking about sexual orientation and concerns related to HIV and STIs, infectious diseases, you'll see people already are kind of hovering around often to very often doing that in the last 3 months. But when it came to asking about anal sex practices or about concerns about anal sex that aren't about an infectious disease, that's hovering around sometimes, so a lower number. And then you'll see that that also increased to be closer to often, while these other ones stayed basically the same. So it seems like we're able to distinguish that we're having an effect on those particular aspects of assessment. And then I mentioned earlier that there seemed to be this role for social support. We had a social support scale, which we looked at back here, but I suspect that there might have been a little bit of a floor effect with that because people thought that they were able to provide that kind of support. So we didn't see much of a change here, but I suspect if we were to have done a different kind of assessment where people could assess their ability to provide social support after the intervention, but think retrospectively about before the intervention, it might have been a little bit lower. But what we found here, when we asked these questions that are a little bit more specific about starting a conversation apart from infectious disease, responding to concerns apart from infectious disease, and then advising on these topics about how to lessen contact with fecal matter, make anal sex less painful and make it more pleasurable, you'll see where people are in the beginning, which is like sometimes or not at all. And then you'll see that they got a little bit closer to either sometimes or often. So these all increased significantly as well. Let's look at service outcomes, because this is ultimately what we're trying to do is influence service outcomes and make them more equitable. So we intervened with the quality improvement in Clinic A and Clinic B, so one in Tennessee and one in Mississippi. And we looked at 3-site testing: urethral, oropharyngeal, and anal rectal collection for STI screening. So before Peaches, the 3 months before we intervened with Peaches, you'll see that about 1 out of 4 patients in the Clinic A were getting anal rectal swabbing, but you see how high the numbers are for these other screens. And then you'll see over here is about 50% for Clinic B in Mississippi, but also how high urethral and oropharyngeal are. And that's not unheard of. It's a common problem, unfortunately. Then during Peaches, we're going to look at the change from baseline, the percent change. And so it increased 60% in clinic A from baseline. And then that was sustained in the 3 months after peaches. So afterward, it stayed at around 50%. So it's a signal. This is all de-identified aggregated data. We're not using any inferential statistics to evaluate these changes over time, but it's a signal that we might be having an effect on service uptake. But there's something curious here as well, which is in clinic B, these numbers decreased. So we can't be so optimistic about clinic A without also considering that something was happening in clinic B, that these things decreased over time. You'll see that they decreased moderately for these others, but they stayed basically the same, but they decreased quite a bit for anal rectal testing. So that begs the question of like, why would that have happened? So we looked at some different implementation differences between clinics. So first off, clinic A had a 5-person QI team and clinic B had a 2-person QI team. And not only did they have more people, but they also had a data analyst as well as an operations manager and 2 clinicians on board. Now, these were clinicians over here in clinic B as well, but you've got a clinic director who's also a clinician. You've just got a little bit more representation, a little bit more organizational heft in terms of people who are pulling the levers within the organization over here in clinic A. And then in terms of the 2 QI strategies, the placement of visual cues, you'll also see that there's more of that in clinic A than there is in clinic B. Clinic B was certainly fine with distributing the materials, but they said, we don't really want to put anything in the exam rooms. We like a kind of clean environment. It really wasn't until the last month of my time with them that I persuaded them to do a trial of putting up the posters. They also didn't put up some of these bubble sheets that we had to prompt discussion. And clinic A also did an assessment of patient acceptability of the placement of visual cues. So there's a bit more effort from clinic A in that area. And then in terms of QI meetings, both clinics spent their time with the QI revising intake and assessment forms, but clinic A wanted to do something to improve their anal rectal STI screening. So they created an SOP, which I helped them to do. And then the last thing is that the exposure to the QI meetings was also different. So there were 8 sessions over 6 months for clinic A and half of that for clinic B. Now, that at first looks like it's a little bit misleading. Like, well, you just had more time with them and they had more time overall to implement changes. But actually, the changes, the uptick in anal rectal STI screening in clinic A all happened before they did this patient acceptability assessment and also before the additional sessions happened. So it all happened within 3 months. So I think instead of looking at it as though they just had more dosage or exposure, it's something, probably an indication of like the implementation climate and their readiness for change that is shown in these differences in terms of their team, their willingness to do this assessment of patient acceptability or capability of doing it, given the amount of people they had, as well as their interest in continuing the QI over time. All of that just suggests that there is probably some signal that environmental changes are driving some of this, but also that there's something, the environment itself involves the clinic and the organization itself. And some of those differences between clinics are important to assess, which points to a future direction. So the take-home message is still that environmental changes drive stigma reduction, but the caveat is we also need to assess some of the baseline differences between clinics and also how those things shift over time at the organizational level. There are a lot of limitations with the project. Of course, there's selection bias in who was willing to participate in PEACHES to begin with. And then I was the purveyor of these different strategies of the training and the quality improvement. And so as people were reporting their perspectives about PEACHES, they also knew that my team, even though I was not the one collecting the data myself, they knew that my team was affiliated with me. So there might have been some reporting bias in that sense. And there might have also been, well, there certainly were some exposure differences. So not everyone participated in coaching calls. Everyone did participate in the workshop, but subsequent coaching calls, not everyone participated in that. As well, we offered the QI to just 2 clinics, but then we offered really anyone, if they wanted to have an ad hoc QI meeting for their organization, we offered that as well. But not everyone took advantage of that. And then, of course, there's questions about causality. We're not adjusting for confounding. It's really just a pre-post over time interrupted time series, but it's interrupted time series in 3-month intervals, 3 months before peaches, 3 months during peaches, and then 3 months after peaches. And so there could be some seasonal effects. So, for example, if I go back here, this decrease in clinic B, one possible confounding factor could be that clinic B is in a college town in Mississippi where there's a very sizable, like 60,000 person student body. And we began peaches in June, and then the patient population dropped precipitously. But you'll see, even during those months, it looks like the patient population is sustained. What they did is they shifted from clinic-based things into outreach efforts, like pride efforts, other things out in the environment, out in the world. And so it's possible that collecting anal rectal swabs outside in the world is a bit more difficult than collecting urethral and oral pharyngeal specimens. So that is something we would need to assess in the future. Okay, so future directions. We have an NIMH R01 proposal that's pending scientific review, and Dr. Katrine Myers is my MPI on that project. Very happy to be working with her again. And there are a couple of things that we are planning to do. One is to refine and standardize peaches as peaches 2.0. And so we're going to do a couple of tweaks to both the training and the quality improvement. So in the training, we had about 20% of the 65 healthcare workers were clinicians, which is quite nice for a 2-day in-person workshop to take that time away. But only 2 of them were physicians. So we were missing a large chunk of the people who could be ordering anal rectal STI screening and also initiating some of these conversations with clients. So we thought if we were to create a clinical learning collaborative with CMEs that would incentivize participation and be more specialized in clinical topics rather than general coaching topics on how to talk about the subject, we thought that might be more alluring and be able to reach more clinicians. And then in terms of quality improvement, we thought about standardizing the collection of the data and using audit and feedback with a dashboard to feed that information back to providers. So, for example, this information was all collected after peaches was delivered. It wasn't during peaches. So you can imagine if a clinic could see, oh, okay, on a monthly basis, we can see what's happening with the discrepancy between anal rectal and urethral and oral pharyngeal. We can see that and also see it by provider or by patient type. That might be particularly motivating to create some change. So we've added that as our proposal as well. We've also specified a causal pathway diagram that we're trying to make as comprehensive as possible to try to understand all of the different factors that could be at play and that we would need to assess or at least consider in that proposal. And ultimately, it will be a hybrid implementation effectiveness interrupted time series study. And it's planned with 8 clinical sites in the Mississippi Delta, a single organization that has 8 different sites across the region. And there are 3 aims. The first is to evaluate impact on provider adoption of anal sex-related health services and patient uptake of those services. And the primary outcome would be anal rectal STI screening, but secondary outcomes would be doxy, PEP, and PrEP prescription, initiating PrEP prescription, and also anal cancer screening. And then we want to do a very thorough test of mechanisms and moderators of impact. So do that statistically, which is something that we weren't able to do in the pilot study for the K23. And then, as I mentioned, these like variable factors between clinics, we want to identify sources of site variability in impact and look at implementation outcomes and do that ethnographically. So more holistic way of assessing all of those factors. Before we open up for discussion, I want to make sure we have you got a little bit exposure to the main resource that we developed that's accessible to anyone. This is our website. It is under construction because we've gotten feedback that it would be helpful to make it a little bit more inclusive of female-bodied people. and also a little bit easier to search. So we've got a consultant who's helping us develop it now. So if you go to this website now, you're not going to see exactly what you're seeing at the moment, but this will give you a sense of what it looks like. So we collected a bunch of resources from the internet. Rather than develop our own resources, we decided to curate things that we found online. And so if you go to it and you scroll down, you'll see each card is a different resource. And you just click there and learn more about it. And you can also filter. So if you're looking for a how-to guide that is gender inclusive, you can do that, and the resources will filter. It's not a perfect system for filtering, but hopefully it's helpful to guide people. But we're looking for a different way of organizing it. So that's why we're revising the website at the moment. And then there's also a page for clinics. This is a 90-minute webinar, which is just the kind of didactic information about physiology and sources of pleasure. This is something that participants in the Tennessee region wanted. They said, we would love for some of our clinicians to see this, but they're not going to be able to attend a 2-day workshop, and you're not coming back because it's a study. So could you do a 90-minute webinar? So we pulled that together and delivered that to folks. So that's available online. And then all of our things that we developed, our intake forms and patient-facing materials are all available as well. For example, here's the poster that's in Spanish. Most of the materials are in English and in Spanish. You also see this is our bubble sheet, which is based in motivational interviewing. It's meant to be something to be handed to a client in a waiting area or outreach event, or just simply during an encounter. And people can check questions that they have or write their own questions. And there's also a set of questions here that you can populate into the bubble sheet. All of it is editable in Google Docs, and it's also in English and in Spanish. And then these are e-screens, just another example of the kinds of things that we offered people to implement in their clinics in terms of client-facing visual cues. You'll see also our selection criteria. Everything that we put on the website as a resource, we wanted to make sure that it was accurate and reliable and reflected principles of justice, equity, diversity, and inclusion, which we define further in each of these areas. So we just made sure we vetted all of those things in collaboration with our advisory board. And then we developed the science library, which I find really fascinating. I'm not quite sure if other people do, but we collected hundreds of articles on the subject of anal pleasure and health, and then put them into a citation manager. And you can access them by clicking this plus, and then seeing a little definition of what this area is, and then accessing those PDFs, usually free of charge if they're in the public domain already. And we continually update this. I should also say that the website is translatable into any language. We have a Google plugin that allows anyone to turn it into their home language. And so here's the website with a QR code, or you can just go to that URL. I want to give thanks to the team of people involved in this. A lot of research participants. I'm very grateful for their involvement and participation over time. The research team has been terrific in my lab, and certainly my research mentorship through the K23, but also other fellowship opportunities. And shout out to Katrine, who I've been working with for years on this topic. Our implementation partners at the Southeast AATC and the Northeast and Caribbean AATC, and these other partners who helped with the development of the webinar and delivery of it, and our wonderful advisory board. You'll see here, 2 of them wanted to participate, but decided they didn't want to be publicized in that way. So it's just an indication of people who have something to contribute, but because of stigma, feel as though they can't do it except anonymously. And then, of course, our funding from NIMH. So I finished a little bit faster than I realized I would. So I think we have plenty of time for questions. And I think we can open up for that now.